Good afternoon, everyone. Today is Wednesday, December 17th, 2025. We are here this afternoon for a work session, and our discussion item is an update on behavioral health services multi-year funding development efforts. I'm Kristen Stevens, Chair of the Board of County Commissioners. With me are my fellow commissioners, Commissioner John Kafalis and Commissioner Jody Shattuck McNally. We have our Lorenda Volker, our county manager, with us today, and I will turn things over to Amy Martonis, our behavioral health services director, for the update, and welcome everyone who's in the room.
Thank you. Hello, Commissioners, County Manager Volker, colleagues in the room, and community members and others who may be joining us online. My name is Amy Martonis, and I serve as the Behavioral Health Services Director for Larimer County. With me in the room are colleagues that have been vital in developing the work that I'm sharing with you today. I'll invite them to introduce themselves in a moment, and wanted to note that online we also have members from the Corona Insights team who will also introduce themselves shortly. They have been our vendor that has supported the work that we're sharing with you today. With that, I'll invite my colleagues to introduce themselves.
Hello, Commissioners. My name is Madeline Novi, and I serve as the Communications Coordinator for Larimer County Behavioral Health Services.
Good afternoon. My name is Jessica Plummer, and I serve as the Program Manager for Behavioral Health Services.
And I'll invite our Corona colleagues who are virtual with us today to also introduce themselves.
Hello, this is Kate Darwin. I'm a principal at Corona Insights.
I'm Matt Bruce, also a principal at Corona Insights and a Larimer County resident.
Hi, I'm Jim Prepotich, a director at Corona Insights.
Hi, Paul Collier here, also a director at Corona Insights.
And Catherine Rocky, senior associate at Corona.
Thank you, Corona team, for introducing yourselves. We'll hear from them a bit further, a bit later in our discussion. So in this hour together, we have a lot to share with you about the multi-year funding planning efforts and community engagement that has been underway since May. Our agenda today includes sharing the desired outcomes for this time together, providing context for the multi-year funding initiative, summarizing the stakeholder engagement, reviewing multi-year funding fiscal considerations, summarizing the options for multi-year funded investments, and discussing investment prioritization and any questions that you might have about this effort. All of the work that we are sharing with you today is grounded in our department's vision that Larimer County is a community where people are empowered and supported in accessing a full range of behavioral health services that promote well-being for all. The multi-year funding framework is also rooted in our core values of stewardship, partnership, and community. We recognize that this work is made possible by our community's investment in behavioral health, and that collaboration is essential to this work moving forward. Our collective efforts are focused on strengthening the behavioral health system so that every individual in our community benefits. The desired outcomes for this work session include sharing about the rigorous stakeholder engagement process facilitated by Corona Insights and what we learned from our community about the current funding priorities for multi-year investments, as well as discussing and determining investment prioritization, which will guide the next phase of our departmental efforts to implement multi-year funding in 2026. Given the diverse strategies used in our department to reinvest the sales tax dollars into our behavioral health system, it's important to ground this conversation in the purpose of multi-year funding. Multi-year funding is a new investment strategy at the system level. It's a way to deepen our community-driven investments in system-wide changes, bring multiple organizations together to solve complex community challenges, affect the greatest impacts across the behavioral health system, and honor what our community and advisory groups have been asking for as part of the sales tax investment. Multi-year funding is not a replacement of the annual Impact Fund grant program that our community is well aware of with 7 years under its belt. And it's also not a way for single organizations to get multiple years of funding for the good work that's already happening in our community. On this slide is a visual representation of our department's community investment strategies that have evolved and expanded in response to community priorities. The short term is our annual Impact Fund grant program. These funds are invested at the organizational level to support continuum of care efforts from prevention through recovery. The midterm is what we're currently developing together with multi-year funding for system-level investments in alignment with community priorities. The long-term investments reflect our departmental operations and the acute care facility at the Longview campus, which includes an array of crisis care services. As a reminder to our community, the acute care facility is open 24 hours a day, 7 days a week, 365 days a year to provide care for those who might be experiencing a self-defined behavioral health or substance use crisis, regardless of insurance status or ability to pay. It's a tremendous resource that we have in our community because of this sales tax. Now that we've grounded this conversation in the purpose of multi-year funding and how it fits within our community investment approach, I'd like to invite our partners at Corona Insights to talk through the stakeholder engagement process, and I'll turn it over to Kate.
Thanks, Amy. I'm here with Corona Insights. We are a small business that's based in Denver, and we provide research, learning, evaluation, strategy, and facilitation for purpose-led organizations. So I'm really excited to talk about the stakeholder engagement process that we used. Before I jump into the details of the process, I just wanted to take a step back and acknowledge that when we started this project, there were a lot of recent plans that were relevant. So the Community Master Plan for Behavioral Health for Larimer County, the Community Health Improvement Plan for Larimer County, the Mental Health and Substance Use Alliance Strategic Plan, et cetera. So all of these plans had come out recently, and a lot of them included a lot of great community engagement, research, and insights about what the behavioral health needs of the community were. So given that we, number one, didn't want to duplicate that research, there already seemed to be pretty foundational understanding of what the community needs were. But then number two, this process was really focused on developing solutions that could be supported with a multi-year funding framework. And so for that reason, we focused on engaging with behavioral health system stakeholders, so those who work and have intimate knowledge about the behavioral health system. And I'll talk about that a little bit more on this next slide. At the beginning of this process, we defined roles of different stakeholders. We also presented this information at all of our sessions this past year. So at the top here, county leadership, obviously it's commissioners who prioritize the investment strategies, which is what we're doing today. Larimer County Behavioral Health Services, we worked closely with them, and their role is really to, given all of the stakeholder input, develop the final investment options and figure out what the funding framework needs to be to best support those. As I noted previously, the behavioral health community, this really focused on people who have intimate knowledge of the behavioral health system. So we engaged with a number of people who have lived experience with behavioral health, but also a number of people who are healthcare providers, who work at hospitals, emergency services, nonprofits, businesses, et cetera. We also convened a small consultation group. So this was a group made up of behavioral health leaders who, because of their role, had a more systems level perspective when it comes to behavioral health, and were able to speak to different solutions and how they might impact the overall behavioral health system. And then finally, Corona, we were the outside consultant who designed this engagement. So on the next slide, this is just an overview of our stakeholder engagement process. As I noted earlier, there were several plans, relevant plans that had just come out. And so we started out this process by reviewing those and summarizing the key community needs identified in those plans. At the brainstorming session, we presented those common needs identified across the plans to get a sense of whether those were still relevant or whether there were other emerging needs that we needed to be aware of. Overall, at those sessions, the behavioral health stakeholders reconfirmed those same community needs. So the needs from those plans were things like addressing issues of health equity, a need for better coordination of efforts to address behavioral health across the county, a focus on supporting non-clinical approaches to behavioral health, a need for better data alignment and sharing across organizations, and then finally, a need for workforce development and support for behavioral health. So at these brainstorming sessions, we invited the behavioral health stakeholders to generate ideas, so solutions, potential project ideas that they thought would have the greatest impact on behavioral health and also be the best candidates for a multi-year funding framework. We had over, I believe, 120 ideas, which we then coded to come up with 10 solution areas. So we presented those solution areas to the consultation group in September. We had them help us refine those so that the different solution areas felt distinct. They also helped us develop criteria that we would use at a prioritization session. So then in September, we had a prioritization session where the behavioral health stakeholders went through those 10 solution areas and ranked them on different criteria. We crunched the numbers and then presented them with the results. There were 3 key solution areas that really rose to the top. That was summarized in one of our memos in your packet. Then in November and December, we worked with the consultation group to initially develop proposals for each of the top 3 solution areas. We had them roughly rank those as well. We then refined those with behavioral health services. We presented those back to behavioral health stakeholders in November to get their feedback on the different options, to ask questions, and then again to roughly give us a sense of their preference for different proposals. Then in October and November, BHS staff further refined the top proposals into the 3 proposals that you see today. We did present those to the consultation group as well to get their input before those were delivered to commissioners. Today we're presenting those to county commissioners, the funding proposals, and then in the beginning of 2026, we'll be working to finalize the funding framework, also to begin the evaluation design, and to give updates to commissioners. And then in Q2, we plan to implement the funding framework and implement the evaluation, which for this project is very collaborative, where Corona will be working with the fundees to figure out the best metrics for the evaluation. I covered, I believe, a lot of this, but on this slide you can just see in the word cloud a list of the organizations that were involved with this process. We had great engagement from organizations that work across the county. We tried to offer both online options and in-person options so that people from across the county could give input along the way. Overall, this process, people were very engaged. I feel like we heard a lot of amazing ideas. I also wanted to be clear that while BHS was, involved with this process, at the actual sessions, they would present on the funding framework concept, but then they were there to observe, not to insert themselves or, sway the conversation any specific direction. And then finally, I just wanted to note that what came out of this process mirrors so much of what we saw in other plans, what is coming up from Behavioral Health Services strategic planning process. And so that's always comforting when data kind of reconfirm other data. So I think whatever choice we make today, these are all great options that could have a really big impact on Larimer County. I'm going to be handing this off to Amy momentarily, but the top 3 solution areas that came out of our prioritization process were behavioral health workforce. So how do you develop, recruit, retain, and also support the behavioral health workforce? Number 2 was cross-organizational incentives. So how do you incentivize organizations to work with each other, and especially create co-location of services, so like a one-stop shop? And then finally, system navigation. So this was specifically from a consumer side. So how do you make it easier for residents of Larimer County to find behavioral health care? And so with that, I'm going to turn it back over to Amy.
Thank you for sharing that summary, Kate. So with this engagement summary in mind, let's turn to the multi-year funding investment options, beginning with the fiscal due diligence that our department has completed to inform these recommendations and this work. Our multi-year funding efforts to date have been shaped by our core values of stewardship. From the beginning, our goal has been to maximize reinvestment of the sales tax dollars while using conservative and long-range fiscal forecasting to ensure fiscal stability throughout the life of the tax. Because of skilled fiscal management over the past several years and the current strength of our departmental fund balance, Behavioral Health Services is well positioned to responsibly invest in and expand these community investments in alignment with stakeholder identified priorities that we're sharing today. Our fiscal planning is informed by a dynamic funding model that looks holistically at our resources and our obligations. This includes our fund balance trajectory, 5-year average sales tax performance, operating performance and third-party billing offset trends at the Longview Acute Care Facility, our stable commitment to the annual Impact Fund grant program, and our projected departmental budget. We're aligning our desire to grow investments with a long-range fiscal plan that keeps us conservatively above our minimum reserve target through 2038, the year that the sales tax will expire unless it is renewed. This approach ensures that we honor our commitment to stewardship responsibly for years to come while reinvesting meaningfully in our behavioral health system today. Our team will be bringing additional specific budget requests and further financial planning details to the board through the regular annual budgeting process, but our aim today is to highlight that this multi-year funding strategy does fit within our broader financial picture as a department. Now we've reached what I think of as the exciting part, and that's sharing more details with you about what our stakeholders have prioritized for multi-year funding. What you heard briefly about, and what's fortuitous, is that this community engagement process was happening alongside but parallel to and separate from our team's development of the first departmental strategic plan for behavioral health services. We're excited to share details of that with you further in a work session in 2026. But we wanted to note that in strategic planning, we had already identified that attracting and retaining a highly skilled behavioral health workforce is key to moving our system forward. And when these community engagement efforts began, this was confirmed over and over again. Behavioral health workforce initiatives were the #1 prioritized need identified through the multi-year funding engagement process. It became clear that one of our multi-year investments must then be in our workforce if we want the other potential investments to be successful. So with that, I'm going to walk you through how our work is progressing in that priority area. Then I'll give you an overview of the other 2 investment options for multi-year funding, which are cross-organizational incentives or system navigation. As we review the multi-year funding options in more detail, I do want to note that choosing a next community investment isn't a zero-sum choice. Each option strengthens the system in unique ways and also carries specific risks, but both have broad base of stakeholder support. While the slides offer a high-level view, more detailed information about each of the investment options is available in your packet. This includes how each investment option aligns to things like the Community Health Improvement Plan, our Community Master Plan for Behavioral Health, and those other foundational documents that Kate mentioned. So first is our investment in workforce. And in kicking this off, I just want to give a shout out to our colleagues in Economic and Workforce Development, as their support and contributions have been vital in how we've identified workforce as a priority area, and they're in support of this work moving forward. Currently, we've repurposed an existing and vacant FTE within our department, and we're hiring for a behavioral health workforce manager position. That recruitment is open with strong interest, and we anticipate having this team member on board with us in February. They'll work closely with our colleagues in Economic and Workforce Development, as well as with community partners across the behavioral health system. The framework for these efforts will be in place when this person joins the team, and their work will be rooted in our theory of action. If we strategically invest in the behavioral health workforce through recruitment, development, and retention, then we'll build a stable and skilled workforce that can meet community needs and sustain high-quality behavioral health services over time. Some of the possible outcomes that we anticipate with workforce being prioritized include reduced provider burnout and improved workforce resilience, stronger retention of skilled behavioral health staff, clear pathways for entering and advancing in the behavioral health field, increased professional development and credential attainment, expanded internship, apprenticeship, and supervision opportunities, and collaborative retention incentives across organizations, having more local providers living and working in Larimer County, which will help us grow a sustainable and coordinated behavioral health workforce ecosystem. As Kate shared earlier, the community engagement process generated over 120 ideas that were categorized and further distilled by the stakeholder feedback until the top 3 priorities were identified. BHS staff and the small consultation group alongside the Corona team used all of that feedback to come up with the more specific drafted plans you're seeing today. Our next focus area is cross-organizational incentives, which means bringing providers together in shared community spaces and with some shared resources. The theory of action here is straightforward. If organizations work together in shared community spaces with aligned processes and staffing supports, then behavioral health care becomes more coordinated, efficient, and accessible. Implementation would start by identifying the services that would benefit most from co-location, and then determining the locations and setups that would best support delivering those services. This lays the groundwork for the projected outcomes you'll see on the next slide. Some of those projected outcomes include having a significant reduction in travel, referrals, stigma, and system friction in accessing care, more consistent access to care in daily community settings, better alignment across organizations with fewer duplicated services, higher satisfaction among staff and community members, increased sustainability for organizations with braided funding streams, more residents accessing care earlier, potentially reducing severity, service duration, and need for crisis care. We also envision that developing a co-location model could be something that becomes replicable and expanded to other locations. The final investment option focuses on a consumer access portal, an easy-to-use tool that anyone in the community could use to connect with behavioral health providers and services. The theory of action here is if we provide an easy-to-access tool or portal that anyone in the community can use to connect with providers and services, then we will get people to the right care at the right time, in the right way, and at the right cost. Some of the anticipated outcomes for this investment strategy would be quicker community-wide access to care options, reducing stress on caregivers attempting to navigate the system, and a shared understanding of resources available in our community that support care coordination across the county. This also supports increased coordination between both public and private providers and higher quality referrals. To make the portal effective, we envision care coordination capabilities that go beyond a static directory and ensuring that the system stays current and useful for our community. So to summarize, our stakeholders identified clear priorities for strengthening the behavioral health system in Larimer County. meeting community needs in alignment with several existing countywide and collaborative plans that have underpinned this work. There's been a significant alignment between work that came before this effort and that was echoed through this effort. The 3 areas that were prioritized are behavioral health workforce, cross-organizational incentives, and the consumer access portal. Each strengthens a different part of our behavioral health system and moves progress forward in transforming our system of care. As we transition to discussion, we'd like to pose a critical question to guide our next steps and with your insights. Of the 2 investment options, which should BHS prioritize now to have the greatest system-wide impact on behavioral health for our community? With that, we'd like to open it up for discussion, and we're eager for your questions.
All right, questions or discussion? Commissioner Cavallis?
Thank you, Madam Chair. Thank you, Amy and colleagues. I have a few questions that would help inform my responses to the overarching questions. Maybe I'll do 1 or 2 and then we can share the love. Well, I guess this might be for the consultant folks, or Kate.
Sure.
If we could get more details, and I think it's somewhere in another document, more details about the stakeholder engagement. And the perennial question that we often ask is, what about rural areas, unincorporated areas? It seemed like what I remember from one of the documents, there were a couple of in-person sessions and 1 virtual session, but both in-person sessions were in Fort Collins, and it just seemed Fort Collins centered. So that would be one question, overarching question regarding how did we engage some of the more rural areas, whether in all 3 districts, and how did we go beyond being Fort Collins centered?
Yeah, thank you for posing that question, and I'm happy to kick off the discussion and invite the Corona Insights team to share further if they would like to. I think one of the important things to note about this engagement effort was that it built on the efforts that were part of the Community Master Plan and the Community Health Improvement Plan, as well as the county strategic plan, and all of those had a broad research base with representation across the community of community voice and community members. Specific to this engagement process, we were collaborating closely with behavioral health stakeholders, so meaning folks that are working within or receiving care within the system, but primarily service providers that would have insights to the care system gaps and needs at a system level of where we should prioritize efforts to strengthen the system. So we leveraged the existing research that had been done that centered community voice in making recommendations, and that was the starting point for the follow-up work we did through this engagement process. So our efforts to extend that reach did include hosting a virtual session, using online surveys to provide feedback for folks who couldn't make it to in-person sessions, and having an open communication loop through our communications coordinator and the community-wide updates and invitations that we have been distributing throughout this process since May.
I think I'd also like to add, with the organizations that were represented during the engagement process, we had some, including those from the town of Estes Park, those that provide services within the Estes Valley. We have organizations that serve individuals in Wellington, in Johnstown, and so we had a mix of both leaders in those areas as well as providers. And then we have across the different organizations, those that serve different populations. So we have some that serve LGBTQIA plus community. We have those who support individuals with disabilities, those who support older adults within our community. So we were hoping through the list of represented groups that it would address what you're speaking to, Commissioner. And you are correct in your materials that we sent over, and we can share them again. Last week, we provided a full summary of Corona Insights work in the engagement process. So all of the data for each of the sessions, all of the compiled data and analysis related to the surveys, as well as a full list of organizations that participated and were represented in the process.
If I may, Madam Chair, just a follow-up to that response, and then I'll hold off on any other questions so we can take turns or whatever you think is best. Thank you. And all of the areas that you mentioned are all incorporated municipalities. What about places that are not incorporated? Like one of my favorite places, Red Feather Lakes, Livermore, places that are more remote, both on the south end of the county and certainly on the north end of the county.
I will say connected to this effort, but also separate from it, our department has been making intentional efforts to reach Red Feather and to grow our network there. Recently, Jessica Plummer spent all day with members of our health department and the CHIP efforts in making connections in Red Feather to support additional behavioral health outreach. And we learned some interesting new things, like there being a dedicated space in the library to support folks for telehealth appointments and ways to access behavioral health care. So we are, as a department, committed to forging and continuing to strengthen those relationships and invite representation into these processes whenever possible.
Thank you for now. Thanks, Madam Chair.
Commissioner Shadwick McNally.
Thank you all for being here. Thank you to Corona Insights. I'm looking at all of this and my mind's spinning, thinking about that first conversation we had, and how many voices in the room, and it was very busy, lots of talk, and I appreciate capturing, kind of who was there and how we talk about this, and there's. Like, I didn't know we had a Larimer Medicaid Advisory Council, so that was something new for me, so I'm just, curious about that. When I look at this, for my first question, when I look at this word cloud, and this leads to my question, is I see, like, certain words a lot, like Arula 3 times, that's pretty large, and some others, and I don't know what Arula is, and I'm wondering, my question is, we had some folks who came that might have represented one organization, or like we had multiple individuals or representing one organization. And even on your small group, you have someone who sits on the board of that organization, and you had the executive director of the organization. So my question is, how do you keep a balance of all voices and thoughts across the whole district? And I'm not sure what a rule is, but I think you and I, Amy and I have talked about this, is, when the time of scarcity, when we get some of the nonprofits who are very concerned and areas, just want to make sure that we're keeping the resource scarcity out of it and maybe focusing on what we're trying to do is investing in system changes that we need to really move the needle. And so that's my first question. I don't know who wants to tackle that.
Yeah, thank you, Commissioner. I'm happy to. I appreciate the question. One of the things that I found really valuable about the engagement process that Corona Insights designed was that at every step of the way, the ideas that were generated from folks that were in the room were pressure tested and reassessed by the group of community stakeholders again. And those multiple steps in the process of reiterating, here's the feedback we received. Now we'd like the group to weigh in on how we're distilling that information, what we hear as the priorities, and give layers of insight and follow up with each round of recommendations. And as they were being distilled, I think I would share that concern if there was one pass of feedback and it went towards implementation. But this was several rounds over months of discussion and dialogue where there were numerous ways for folks to engage and test the ideas, challenge the ideas, provide new ideas into the conversation to really hone in on what was amplified as community priorities. And in the representation across all of the engagement, I didn't see a trend where one interest area across the continuum of care was amplified or highlighted more than others. It was a broad base of strategies and solutions.
Great. My next question, venture. Good to know. I like how you said something and challenge. So
Pressure testing?
Pressure testing. Yeah, I appreciate that very much. My next question is, well, I guess twofold. We have almost 2 full years of data of folks coming into Longview. And they've come, and I know we've collected where they're coming from, and when we talked about the rural outreach. We've seen some really encouraging numbers coming from some of our more remote rural areas. Is there any information when we talk about lived experience gleaned from, are we also utilizing those users, clients, our residents who have accessed, who have driven up and basically, I mean, that's the majority of them, right? How are we also using those experiences to help maybe guide? I mean, I have no concerns about these. I will ask, my next question will be about these options, but how are we also using that to help guide some of these priorities?
Absolutely. Thank you for the question, Commissioner. When we think about the overarching options that we're presenting today and what it will mean to move from the ideas of what the investments could be to the implementation phase, that data will be critical in highlighting on the co-located services side what services and care coordination post-acute crisis are most needed to centralize in our community. And on the referral hub option, that's a vital service that's provided from acute care. What's the care that comes next? How are folks accessing it? And how is it being coordinated? So that data will be really critical as we think about what implementation starts to look like with either investment option. Will be a critical part of the puzzle.
And to build on that a little bit, that's, after the fact or after intervention, are we also using that to maybe backtrack and see how we could upstream to maybe delay or maybe even mitigate intervention by early access intervention? I'm just curious about that.
Yeah, I think that would be a telling data story and inform efforts on the coordination side ahead of an acute crisis. And I know that care trends and how folks are accessing care is some of the data that Summit Stone provides in looking at how folks eventually receive care at Longview. And I think we're missing pieces that we can glean further from a broader base of our providers across the community for folks who have private insurance or not represented in receiving care through the safety net system and the services that Summit Stone provides. But all of that utilization data would provide a comprehensive picture of that further inform where those gaps are and how either of these efforts would strengthen the continuum and hopefully avoid the need for crisis care in some cases by having that wraparound and coordinated support throughout.
I love your answer. Thank you very much. And one more question, then I'll put my other one in the parking lot because
Sure.
maybe you'll have, my colleagues have the same question. But you're asking us to make comments on two options. But also, when you talked about the three top strategies, there's three. Workforce, we know that has been something we talked about before the building was even built. It's something that even with, but wildfire mitigation, the workforce and the skills are very important. So it seems like you've all identified this is something we should invest in, so that's not an option. So my question about this, because for me, seems to be a lot of Johnny come lately, this is the new career of the year, so we're going to offer this little short 6-week to get qualified as our peer-to-peer navigator. And so as we're investing in the workforce or thinking about that, are we also looking to help our partners who are maybe educating what kind of criteria or what kind of skills? So we're getting really, I think it's really important area to have really honed skills, even with peer-to-peer. To help them also not have the burnout. So how are we helping maybe shape or influence kind of what this workforce is learning or how they come prepared? Because the landscape's changed.
Yeah.
And the reason I asked I'm interested in this question, I've been listening to Inside the Brain on NPR, and they've been talking about the Stanford researcher who also found that she had something she wasn't aware of about addiction, that she fell into it, and it kind of impacted her career, and was reading books, a certain type of book. And so it was very fascinating. But it was really interesting to me that talking about where we're at currently in our society and how smartphones and everything, it's almost like immediate access to something that could be influencing our mental health, our behavioral health on a daily basis, and we're glued to these things, right? And so I found it very fascinating about that. So I think now we have the need for better, trained, or more comprehensive thinking about how we live in different times. So how are we looking at influencing this
Yeah.
to make sure we get kind of the workforce we need.
Yeah, thank you for that question, Commissioner. Any workforce effort is going to take a tremendous amount of collaboration across professionals that are part of the equipping, training, mentoring components, our training institutes, institutes of higher education, our community college partners who have launched the micro-credential of the Qualified Behavioral Health certification that supports the peer workforce and that licensure process, as well as more traditional academic training programs in psychology, human development and family studies, social work, counseling. And while some of those programs are governed by specific accreditation bodies that structure the curriculum, our community has strongly engaged providers that offer tremendous amount of real world experience to help shape and inform and make the transition from content and curriculum over into practice. And so by building a network where that is intentional collaborative effort, I think it strengthens the mentorship opportunity and provides some critical partnership in launching the workforce. But one of the other things that we're really excited about when in thinking about the workforce is an opportunity to reframe and redefine what retention looks like. And we hear from our organizational partners how they're struggling with it at an organizational level, and what an opportunity to define retention at the county level and structure. If you're interested in behavioral health, here's why Larimer County is the place to be. You can know your entry point into the workforce. You can know which organizations are for beginning professionals, which are for licensed professionals, and which are for advanced professionals. So to think about having an opportunity where I can envision my career continuum and reframe what retention looks like and make it countywide instead of in an organizational silo seems like a tremendous opportunity that we feel well positioned to take on in supporting our workforce from that education and training side all the way through the career pipeline.
Phenomenal. Love. I know we'll leave my last question about navigation, and unless my colleagues have other questions, I'll pass and hopefully maybe we have the same question. So
Thank you, Commissioner.
thank you.
So I just have a couple questions. How many years do we mean when we say multi-year?
That's a great question, and I think it will be in part defined by the implementation phase when we develop a more specific project plan, a more nuanced budget forecast, and understand the scope of what the work will require. We do know that both of these options have a long tail in terms of it's going to take a building phase to initiate implementation, then a period of it being active, refining, and testing, but we see this as being system-changing efforts. So multi-year, anywhere from 3 to 5 to 10 years through the life of the tax.
And then, with regard to some gaps that are becoming more evident as we kind of move through the year around in different programs, for example, like I'm thinking about permanent supportive housing and some of the dollars that they've lost, and just other programs. I mean, Medicaid being, the uncertainty around Medicaid and stuff like that. When we're obligating, and I don't know about obligating, dollars, year after year. I mean, what are some of the parameters around that?
So there is caution around obligating future boards to current expenses, but what they're looking for here is direction that it's okay to plan over a series of years. Obligating is something different. That's part of the budget process that Amy talked about. That's where we put the money to the program, but knowing that we, in theory, have a program that will last over time and that we will try to fund it appropriately over time, barring something else happening. I think that's the direction we're looking for.
Okay. So I guess thinking about tying up some of these dollars, not necessarily obligating is maybe not the right term. Like how, does it prohibit our ability or, lower our ability to be able to pivot when different things come up? And I just think about, whether this is like people losing, Medicaid funding or that, or maybe having to, there's a recession. I mean, I'm assuming that like the what you're talking about with your budget is that you've planned for some recessions and other kinds of things to happen. But I guess the flexibility of the dollars once we kind of go down this path.
Yeah. Thank you for the question, Commissioner. I recognize how fiscally uncertain these times are. And one of the things that our department appreciates in the community's decision to pass the sales tax in 2018 is that our dedicated funding stream is, the oversight of that is the ballot language that directs the funds to be invested in and supporting the continuum of behavioral health care. So within that awareness, we feel confident in looking at our average sales tax performance and the third-party billing offsets at Longview in forecasting the comfortable margin that we have to make these additional community investments. I'd give a shout out to our accountant, Sean Acosta. He has developed a responsive funding model where essentially we earmark and propose a funding minimum to support the framework of these programs, and then using all of those factors that I mentioned earlier, depending on sales tax performance at Longview, other fiscal trends, it adjusts the maximum amount per year with our long-term fund balance through 2038 in mind. So in real time, we can adjust those numbers and know how much we need to shift the target while still bringing forward a budget recommendation of a minimum amount to fund this new additional investment strategy. So we're excited to share more about that model with the county finance team and through the budgeting process, but there's been a tremendous amount of effort that's gone into how do we stay flexible in these uncertain times and to be responsive to emerging community priorities while still gaining ground on moving the needle in our behavioral health system.
No, I appreciate that, and, I think it's smart to keep looking forward, filling in holes at some point is also important, so we're not losing ground, right?
Absolutely.
And so, thank you, I guess it remains to be seen kind of where we, I don't know, not to be bleak, but there's a lot of things that are coming up lately where we're just seeing these, these gaps, and I'm sure your nonprofits are seeing that as well too, and so, and just people's, the whole insurance, it's not just Medicaid, it's people that might not be able to afford their Affordable Care Act insurance in the coming year too. So, I guess everybody in this room is aware of that, and so I guess it's just I want to make sure that as we think about this, we're sort of, making sure that we have dollars to address some real needs in our community that we might see.
And I think, the tax was passed to be additive to what was already existing in the community. And what's happening now is we're seeing a bit of a loss in some of those. And so shoring up the loss may not help us push forward, but it can help us hold our ground, kind of. And I think that's maybe what we're talking about here is flexible enough to say, wow, we never expected this to happen. We now need to back up and make sure we maintain the foundation before we add more to the top layer. So
Thank you, Lorinda, for saying it better than I ever did, but that's kind of what I'm getting at, exactly.
And if I may add, I think what's unique about our investment strategy is that we have the suite of the short, mid, and long-term investments. And so what I hear underlying in your question and what you're posing, Commissioner, is we have dollars to be able to make system-wide change that we may not ever be able to do again in our careers. That could last for decades. And in the meantime, we have things like the annual grant program that can be more responsive to needs. In the 2025 grant cycle, we have the Family Housing Network, and we have Housing Catalyst, and we have all of these different groups that are living every day responding to the needs in the community. And so we have, by structuring our investments the way we have, the ability to pivot, not only keep things moving at this high level, but meet the needs that are coming up here every day. And so that's where I find solace of thinking, wow, we actually can do this in a responsible way and meet those dynamic needs.
Thank you. Other questions, Commissioner Kafalis?
Thank you, Madam Chair. Thank you once again, colleagues. Just to try to stay focused on this resource discussion, I appreciate all the comments, and I'm wondering, regarding this model that allows us to adjust fund balances, in the long term through the life of the sales tax, and I guess based on what I'm hearing from Commissioner Stevens, can it be adjusted? Can this model adjust if we have to backfill, funding, for Summit Stone, because we know there are going to be Medicaid cuts over the next 10 years. There are different work requirements, the mention of people that are getting private insurance through the Affordable Care Act, or what's left of it, I suppose. So can the question there is, can the model that you speak of adapt or adjust, not just to sales tax performance, but other things? And then in the spirit of here's an idea, maybe by some chance you haven't thought about it, which I kind of think is unlikely, but I'm wondering, since back to the workforce thing, one of the needs, of course, is regarding pediatric care, little ones who need behavioral health services. And given that the voters just approved referendum 1B, is there the potential for leveraging resources because a chunk of one of their focus areas is workforce? Could there be a collaboration where money that we have from our sales tax could be used with money from the 1B sales tax to maybe train higher, folks who are focused on pediatric care? So,
Yeah, thank you for the question, Commissioner.
of course.
It is a core value of our department to center stewardship and how these sales tax dollars are reinvested, and we will explore every opportunity to leverage existing funding within county resources as well as community resources in thinking about the additional sales tax ballot measure that was passed, thinking about our partners at CSU that have been awarded workforce support dollars through the BHA for funding, collaborative partnerships and having multi-stream investments supporting this work will be vital to the sustainability planning. So we will certainly center that in thinking about implementation.
No, and I appreciate that, and I'll stop after this, but I'm wondering, as we work towards finalizing the contract for the delivery of services as a result of 1B, can there be or should there be some specific provisions in there that create some intentionality perhaps around this, the braided, you use the term braided funding. Could this be a potential source of braided funding?
I would welcome additional follow-up with county leadership and exploring those possibilities, certainly.
I'm done.
Thank you. Commissioner Shattuck McNally.
So back to what you had asked us about today. So certainly the workforce is not surprising for me. There was a lot of great ideas, but I think the workforce is definitely something I understand I need because we can't provide services if we don't have specially trained folks. But when I go back to thinking about option 1 or 2, that's what you're asking, that's, I hate to have to choose from 2 of them, but I was just thinking about this just for some feedback is one thing that we have with impact grants, we do have some of that flexible funding for emerging technologies, and we just to remind folks, we did the shortcut for folks who have had 5 years of funding, and so it was a little easier, but we still have that, and that was targeted, but we still have some room for some emerging technologies or flexibility, so that's still there. So there's some flexibility there. So I wanted to highlight that, but one of our focuses is allowing or focusing on collaboration and cross partnerships and working. So that I think that's maybe kind of embedded throughout everything we're pushing. So my thought as I was thinking, because I was trying to think about your question, is organically, maybe that might happen with that organically with as we're going along. So if we're going to think about what might be the one we can invest in, I was thinking system navigation. Because, and I don't know how that looks, it could be an app, it could be like a no wrong door kind of philosophy, or a phone call someone can pick up, or a crisis, and direct them into certain ways. Because whether it's an older adult, and when you're in crisis, you can't think straight, you don't know if you should use your app, your phone, drive, whatever, but like kind of some no wrong door in that system navigation. And I've heard this a lot. A lot of folks don't know, or even providers, right? How do we get someone help right now? Or how do we get them into a warm handoff for that next layer of care, and then the next layer of care? So but that might be needed going forward, especially as folks are running out of options with insurance and things like that. So maybe building a system, because I know this is a discussion with the Youth Mental Health Task Force as well, having the school districts coordinate to having one system for how teachers and parents get how we access help for students or youth. So this seems like this kind of overlaps or is happening at the same time. And so, because that was, I think it ended up being one of the top 3 or 4, right? If correct me, Amy, because we're both in those meetings. Building a system countywide to help bring, because our landscape is dramatically different since 2016, 2018. So how do we help everyone work together and maybe build this system that everyone can access? And then I'm thinking organically, even though we have to choose one option or something, this might happen organically. That's just kind of my initial, because I know we're almost out of time. That's my initial thought. This has been bouncing around in my brain a lot because it just seems like every day we're learning. I mean, I'm just learning something new about the human services stuff that's happening. So I guess that's where I would go right now is I feel like I've heard this a few different, the Youth Mental Health Task Force, and we've heard this here and I've heard this here, like the regional opioid abatement. So I feel like maybe that would be across sectors or across organizations. That might be if we built, and I don't know what it looks like, but I know what you're thinking. I'm thinking an app for some folks, a phone call. But how do we do that to help someone in crisis or someone who is trying to avoid a crisis get, so there's no wrong door. They're not say, oh, well, sorry, we can't help you. Here's a phone number. So that's kind of where I'm leaning. So I hope that's helpful. Thanks.
Thank you, Commissioner.
Thank you. Commissioner Falls, did you want to answer the question at all around options, the 2 options?
Thank you, Madam Chair. And I'm not prepared to answer that question at this time. I have quite a number of other questions, and I don't want you to get the wrong idea in the Corona Insights. I think this has been a terrific process. I think it's great, but I'm afraid I do have questions, and I'm going to suggest that if you all, we can find a specific time to meet, maybe for an hour, either with Lori or some of you folks, so we could have that conversation.
Absolutely.
Sometimes I do better one-on-one, and we don't have any time.
I was going to
To
suggest
the
that as
Corona
well.
folks, thank you, and to you, thank you. I think this is really a terrific process,
Thank you,
honestly.
Commissioner.
I think each of the commissioners may have a different set of questions, and so I wonder if some one-on-one meetings might be the next best step.
Great.
And we can work with Melissa to get an hour scheduled for each of you to go through some of these ideas and the history.
Yeah, I think that would be really helpful as we're running out of time. And, I think that I hear what Commissioner Shattuck McNally says, and yet, I sort of love this idea, in reading through some of this of, kind of identifying duplication and gaps and things like that would happen with the co-located behavioral health services. So probably just a little more information before we kind of give you, and also really want to hear, what you're thinking, because this is not my field of specialty, and, I don't, I would hate to suggest the wrong solution here. So we'll look forward to those conversations then, and then it's 2:59, so we'll adjourn for the day and to be continued. Thank you.
Thank you so much.